Okay. You're recording.
Okay, all right, so the first thing is an understanding of the joint, and I know we have people with different levels of knowledge of the joint, and I think everybody knows kind of where the joint is. The condyle, or the bony part of the joint, the head of the joint, sets in a little cratered area called a fossa. There's a cartilage disc that fits over the head of the joint that's attached to a ligament. And as we open and close, that disc should move with the head of the joint. Sometimes the disc will slip out of place in a patient, or you'll notice clicking or popping in the joint. Sometimes other people will hear it, just somebody's eating or that. And there are different reasons that can occur. I keep referring to my notes, make sure I don't get this joint is different than any other joint in the body in how it functions, and the other unique thing about it is the only thing that determines joint position is your bite. So that's when we treat TMJ problems with an orthotic. With that orthotic, we're repositioning that joint in the joint space to take stress off the joint and stress off the disc and stress off the muscles. Muscles will function from their, they normally want to function from the resting length, so when the jaw is relaxed, whatever position that jaw is in, that's the resting length of the muscles. And then when we bite or chew, those muscles then work to pull the jaw back to get the teeth into occlusion. So some people, if their jaw really wants to set down and forward more, and then if those muscles are constantly having to work hard to pull that jaw back to get the teeth together, it can induce spasm or tension in the muscle, and it'll feel like a headache, especially in the temporal area behind the ear to the neck. So there are different components of TMJ problems that can be related to the disc, or the clicking or popping, or inflammation in the joint. That inflammation sometimes will feel like an earache, stuffiness in the ear, ringing in the ears, or you can be the muscle component where you frequent headaches, difficulty opening or closing, and those types of problems. When we do an exam, so we'll have patients that will come in specifically because they know they've got something wrong with the joint, or they've seen their physician or an ENT, ear, nose, and throat doctor, and they say, no, you don't have, nothing's wrong with your ears, it's related to the joint. And so they kind of have some clue that they've got a TMJ problem, and so the patient will see us for that, or when a patient is in the chair when we're seeing them for a recare appointment or restorative appointment, things that we always want to notice are areas where they have a lot of wear facets on their teeth, chipped or worn anterior teeth, reclined lower anterior teeth, abfractions in teeth, or the notching at the gum line. All those things are indicative of stress or trauma or grinding that a lot of times is associated with TMJ problems. Let's see. So when we're seeing those things on exam, usually then we'll just kind of bring up to a patient, do you ever have soreness in the joints, or difficulty opening or closing? Do you have problems with headaches or earaches? And then they may or may not. If they don't, I would just alert them to the fact that because of some of these things we're seeing, you may have those things may present themselves at some point. The other thing that you can do when you're looking at a pan-oral or full mouth X-ray is the condyle, or head of the joint. It should look like a round ball. People that have a lot of wear of the condyle or bony part, the condyle becomes smaller, and they call it beaking of the condyle. So rather than being round, as it beaks, it'll look like a bird beak. And so sometimes you just see the X-ray and you see this beaked condyle. Just ask the patient, do you have any symptoms in the joint? As that condyle beaks, you have less stable of a surface for that disc to function on, so the disc is more apt to slip out of place, and inflammation in the joint develop in that. And again, the reason for the headaches in the temporal area too with TMJ is that the temporalis muscles are the muscles that bring the jaw up should. Again, they'll spasm, you get headaches in the temple area. Sometimes you can get spasm of the masseter muscles. So again, on exam, you know, you can just palpate the muscle, just with thumb and finger, just kind of feel the muscle. It'll feel like a knot, and it'll be tender to the patient to palpate it. You can check one side versus the other. Also, to check the joint, if you just put your fingers in the patient's ears, just gently push forward and have them open and close, you can feel the disc displace on one side or the other. You know, you can also palpate the temporalis muscles by just kind of holding the temple area and having bite or close. So those muscles contract. Again, if there's spasm in the muscles, they'll be really tender for you to touch or palpate those areas. Also, if a patient comes in and they've started having problems, but it's just been maybe a few days, certainly if it's been 2 weeks or less, usually we'll recommend a soft diet. Certainly no chewing gum or things that are chewy. Recommend ibuprofen to reduce inflammation in the muscle, avoid opening wide, and then seeing if the problem resolves on its own. If somebody has a true TMJ problem, those symptoms will persist, or you know they'll say, yeah, almost every day I have a headache, or you know they notice the symptoms on a more regular basis. Because there isn't a surgery to replace the joint, or the only real surgery now for TMJ problems is to remove the disc and kind of flush the capsule out and clean up for any debris that may have resulted because of wear of the joint, but there isn't a replacement for the disc and joint. We always want to take care of TMJ problems as early as possible, because once that joint wears out, there isn't a replacement for it. Also, with the clicking of the disc, people that have clicking, I'm going to need some of my cough drops. People that have clicking in the joint, again, if it's because of a little wear at the head of or a little wear of the disc, or if they've had an accident, people that have a whiplash type injury, as the head comes down and back, the jaw displaces forward, you'll get tearing of the ligament or stretching of the ligament. They call it a sloppy disc. The disc it's kind of like taking a watermelon seed between your fingers and how it just kind of spits out of there. That disc will kind of do that. I'll hear that kind of a popping. Those kinds of problems, even with treatment, they're always going to have some joint noise, so I'd never tell a patient with treatment that noise is going to go away. We can get rid of other symptoms, but I can never tell anybody that the noise itself isn't going to.
What's the sleep position that you recommend?
The what?
We have here on like.
Yeah. So also on sleep positions, you know, if you have inflammation of the joint, you're having a symptomatic joint. If you lie on your side with a pillow, you can just put a pillow underneath your jaw, and how that pushes, that will aggravate the problem. The ideal position to sleep in, to hold your neck and jaw in a more neutral position, is to ask the patient to try to sleep on their back. They'll probably wake up in a different position. Sleep on their back, take a towel, roll it to about the thickness of your wrist, and put it into your neck, and that holds your neck and everything in the most neutral position. There are cervical pillows. Some patients will have if they have neck or back problems. Cervical pillows tend to be too thick, and they say really to get a more ideal position. Has anybody seen a cervical pillow? Mm-hmm. It's kind of flat, and then there's kind of a lower area and a hump, kind of to allow your head to set down into the lower part, and then the rolled part to fit into your neck. But usually that rolled part's too thick. They say usually, you know, if a patient wants to use that, they should cut that in about half, the rolled part about half the thickness. Thank you. And again, yeah, as I'm going through this, if I'm skipping over other stuff, we have questions. Stop. So also, if a patient has had an accident and that's caused the TMJ problem, again, we still will recommend, you know, soft diet, ibuprofen and that for a couple weeks. But if they come to you and they say, well, I was in an accident and a couple months ago, and now I'm really having a lot of trouble opening and closing, having those issues, you really want to get the patient in and get treatment started as soon as possible. Or sometimes they'll say, you know, ever since I really can't open completely, or, you know, or I don't close all the way. And so that's a sign of a displaced disc. And the longer the disc is displaced, the harder it is to get back in position. So again, you want to treat those problems as sooner the better. Sometimes with an accident, especially if they've had kind of a neck or whiplash type injury, a lot of times as far as the TMJ, the problem doesn't show up for maybe 2 or 3 or 6 months. So it's something, you know, if they comment that they've had an accident like that, it'd be something to tell them to watch for those symptoms developing, because that's a possibility. So when we do our testing, there are some different components of it. First of all, there's EMG. It's electromyography. Basically, we use electrodes opposite the muscles of mastication, the muscles associated with opening and closing and chewing. So we place electrodes on the masseters. We place them on the temporalis, anterior and posterior temporalis, and also on the digastric that are associated with your tongue. One thing also when you're on exam, you know, if you're looking for clues that somebody might have a TMJ problem, watch for a scalp border along the sides of the tongue. Patients that have problems with the joint, just their tongue will want to set between their teeth to act as a brace or support the same way the orthotic would. And so if they've done that chronically, you'll start seeing the scalp borders on their tongue. So when we're testing that digastric, we're testing for that tongue activity or how that muscle's function. And so when we do that testing, we're testing, you know, when the patient's relaxed and how the muscles are firing to get an idea of what muscles might be in spasm. And then we also have them open and close and again see how different muscles groups are functioning, if the right and left side are functioning together or certain groups are functioning harder than others. The next part of the test is electronaphography, pricing the TMJ room, that headset. It's a headset we put on. There's a magnet that goes on the tissue below the lower front teeth. And basically we have you go through opening and closing, get a healthy joint. The jaw will track straight up and down. If you have a degenerative change in either joint or displaced disc, you'll see deviation. So that unit measures any deviation and also the timing of deviation in the open and close. The more degenerated a joint is, the sooner the joint will displace on open. So, you know, you're always hoping if you're seeing that deviation, it's occurring later in the opening phase of any movements. The next thing we do is joint vibration analysis. Again, it looks like the little headphones that are back there. Basically, those, when they put that headset on, it fits just in front of the ear or just over the joint. And as we have them open or close, that's recording any vibrational changes within the joint on each side. And then that also correlates to, again, the timing of the open and close phase, so we know when the disc is moving. There are different, with those readings also, it quantifies the energy behind each vibration, and there's a correlation between that amount of energy and different types of degeneration. So we're looking at those numbers, the timing of when it happens and all that to determine you know, what type of a problem the patient has. So basically we use that as diagnosis. So, you know, going to be treating a problem, we want to know, you know, what the problem is we're treating. We also then have a recording that a year or 5 years from now, we could go back and recheck how they're functioning versus how they originally were. Are they having further degeneration or are things stable? If we're doing an appliance for a patient, we usually like to do that joint vibration yearly, at least for the first 2 or 3 years. Then we may spread it out a little longer than that. Again, to tell us that the appliance is doing.
Sorry, you said JVA is yearly?
Mm-hmm.
That's the only one that's yearly?
Yeah.
Okay.
We would only take them through the other testing if they started having a lot of symptoms that stable with the orthotic. So that we take impressions of the teeth, alginates, because the appliance is made on the lower arch, we pour that in the blue or green stone. The upper can be poured in Yellowstone. So what we would do then is, while we have, basically we're monitoring the screen that shows, I guess the next part is we use a TMJ unit, and basically a TMJ unit pulses the muscles to relax the muscles. There are different types of TMJ units. There are TMJ units that are made to block pain. People that have chronic pain sometimes will have a TMJ unit. They'll have it on all the time, and basically it's putting a pulse to a nerve to try to block the pain. This TMJ unit is set, it's an ultra low frequency TMJ unit. It pulses the muscles to relax the muscle. And again, when you want to remove any spasm in the muscle, and again, find out where that resting position of the jaw is. So we use that TMJ unit usually for about 45 minutes to an hour. And then I come in and again, we kind of look at the tracings, and they're open and closed. And then with that, we're able to determine where that bite should be. We take a bite relation with some stinky bite relation material, but it's very accurate. And then we send that to the lab. It takes about a week to make the orthotic. The orthotics we make are lower orthotics. You probably know, maybe offices you work in have upper appliances, and they usually have a patient just wear those at nighttime. A patient really can't talk with those, and it's not comfortable to wear something like that 24 hours a day. We do a lower appliance because of, again, how the jaw functions, and the bottom part is the one coming up into the upper jaw. It's also less cumbersome for the patient. They can talk with these. You'll find that because we do the testing to find out where the relaxed position of the jaw is, when you do an appliance like this is where their jaw really wants to be. And so very seldom do you find patients that complain about it being cumbersome, or they just can't wear it or talk with it. The first couple weeks there's some adjustment, but they become very protective of the appliance because things feel a lot better when it's in place. So anyway, what else should I tell you about this? So we'll ask a patient then to wear the appliance 24 hours a day. They only take it out when they eat. And again, the reason we want to do that, if they were just wearing it at nighttime, say any correction or reduction in inflammation or break the joint's going to get is just during the time the appliance is in, and then if it's out, 16 hours a day, then everything's going to tighten back up, and it just takes longer to get the patient comfortable. But when they wear it 24 hours a day, we see them 2 weeks after we insert it. As inflammation reduces, discs change position, muscles relax further, then it'll make a slight difference in how the patient hits on the appliance. And we're checking to make sure they're closing evenly on it. We want to make sure that we're not having any interferences with the bite in the front part of the appliance, because that'll trigger, again, anything that hits in front or interference in front is going to cause a problem in the temporalis, because those muscles are working really hard to try to get that jaw back away from that interference. That's why, too, you'll see, again, the wear of upper and lower front teeth, or the reclined interiors, are because of those interferences, because the way the jaw's wanting to sit more forward. So we see them at 2 weeks for adjustment, then we see them once a month for 2 to 3 months. Most patients will wear it full time, 2 to 3 months. At that point, 98% of the time they're comfortable. Then we start gradually decreasing the wear time. You don't want to go from wearing it full time to just wearing it part time. It's just too drastic of a change for the joint and muscle. So we start weaning them off the appliance to find out what the minimum wear time is going to be for them to remain comfortable. Again, probably 95% or more of the patients are able to get to evening or nighttime wear. But we have them reduce it about 2 or 3 hours first thing in the morning to do that for 2 weeks. If they're doing well at 2 weeks, then they leave it out all morning for 2 weeks. Again, if they're doing well, then they leave it out 2 or 3 hours in the afternoon as well. Doing well, then they leave it out all afternoon, and then we ask them to they're doing well at that point is to just put it in at night after dinner and then wear it at night while they sleep. Again, the purpose of that is to reduce any inflammation that could result over the course of the day, because again, whatever that jaw position that caused the original problem, so that we're giving that jaw a break for that period of time. And again, in most cases you find patients will do well, sometimes kind of forever wearing it on that basis. Some people that have more degenerative change in the joint might get along fine for say 6 months or a year, and then they start having symptoms, and what we tell them, if the symptoms are coming back and lasting, you know, a week or more, then we ask them to go back to wearing the appliance full time. The first thing we want to do is have them wear it full time for 2 weeks, and then we'll see them at that point. And then if they're doing well again, we'll gradually decrease the wear time. So again, because of sleeping position, because of something they've eaten or whatever, they could, you know, cause maybe recurrence of some symptoms. And so that's how we kind of get them back into position. People that wear the appliance, you know, every night, usually the life expectancy of the appliance 3 to 5 years. We have a lot of patients that have worn it longer than that and do fine, and their testing still comes out fine. But again, normally we tell patients 3 to 5 years is the typical life expectancy. Now, some things that Beth or the front desk might be able to tell us. So when we do the appliance, to my knowledge, the fee includes adjustments for the first 3 months. Then after that, there should be, if somebody does need to come back in for adjustments or that, there would be a follow-up fee for that. And then if they come in for their yearly JBA, there's a fee for that JBA. Typically with, again, they can tell you more, but I think most dental insurances do not pay for.
The only dental insurance that potentially could pay really is Delta Dental, and the max that Delta Dental will pay is $325
Yeah.
towards it. Very, very rarely does dental insurance cover it. It will typically go
Right.
through medical.
So some things that when you know, I started doing this in seminars I went to, one thing that they, you know, so what insurances would do sometime is down code it to a night guard. And there's quite a difference between a night guard and this, what goes into fabricating it. So this is called an orthotic, and so technically it's a craniomandibular repositioning device. So when you have this in place, it's repositioning the mandible with the cranium. What's supposed to happen medically, there probably been some changes in insurance laws since whenever, but you know, if an insurance pays for other type of orthotics or joint related problems, they shouldn't be able to deny a TMJ. I think there was a period of time that I think they did, some insurances did write exclusions for TMJ problems.
Most insurances they'll be written within the policy, and most employers have to pick whether or not there's going to be a TMJ rider within
Yeah.
the policy.
Yeah. So anyway, we've been doing this a long time, since the 80s, and I think we have good success rate. I think you could ask Crystal or Becky or anybody that's been here for a long time what our success rate with the appliances.
What would you guess it is? Percentage?
95 that accept the treatment.
Yeah.
Mm-hmm.
But
They stay faithful to it. It's like a pacifier to a baby.
it
They baby.
you know, I mean, I can't think of, I mean, in all these years, I mean, we probably have a couple of patients that where the orthotic didn't like it or didn't.
And most
Got
times
one
if
of
you're
those
doing
right
a
now.
crown underneath, a crown will fit, but like bridges and stuff like that, does it have to be remade? Okay, and they go through all of this testing again to remake it?
Well, so a lot of times, I mean, if it's been recent, if it's been within that 3 to 5 years, I might go back through the testing. I wouldn't charge them for the testing, but you know.
And can you hit on real quick just why a patient with TMJ would not be able to wear a night guard?
So the people that have a true degenerative change in the joint, that joint is gonna be very sensitive to any change in, say, if it's not positioned in just the perfect position. I mean, if you do just a small occlusal filling, and if there's a little high spot, it can really, somebody that has degenerated joint, it'll really make it symptomatic. You can put a night guard in, and maybe somebody can say, well, you know, I felt like I did okay for a few weeks, and then now my problem is just worse, or I just don't wear the night guard, it doesn't work. Or patients that sometimes have had TMJ treatment elsewhere and they haven't had the testing to know muscle position and as well as joint position. They'll say, well, you know, I've had the treatment, it doesn't work for me. Yes, well, have you had the testing, and have you gone through complete diagnosis and all that? Because again, if it's not holding the joint in the correct position, it's gonna make the joint more symptomatic. So also going back when you're doing your exam and you see wear facets, fractions, all that, but the patient is asymptomatic, then what I would tell a patient then is that you've got a lot of warning signs here that if you don't have a joint-related problem now, you could or you may in the future. So something you consider is a night guard at this stage to help protect your teeth, but also to be protective of the joint. But the one thing I would just know that if they may say they don't have a joint-related problem and you put the orthotic in, then they might come back to you and say, you know, now my joint hurts.
Or the night guard.
Yeah. So I mean, if you strongly suspect or you palpate the joints, and you can feel the disc move, you see all that, I would be very hesitant to do a night guard because, like I said, you can trigger something and then they think you've caused the problem.
I think too that would fit in right now is sometimes they'll buy the mouth guards for night guard over the counter, and they're soft, and a lot of the chewing motion aggravates the joint.
Exactly.
Or Bruxy's is firm, but sometimes they'll still want to sit and chew on it, and that
Right.
aggravates the joint.
Right.
So like you said, if
Right.
the jaw's
Yeah.
not positioned right, that's going to interfere
So
with that.
there are appliances that you'll see people that do appliances that are a softer appliance, and like Becky was saying, it's just like having a piece of gum in your mouth, and they'll clench and all that, and then boy, it'll just really fire things up. So, you know, sometimes you can put something in, whether it's a night guard or something over the counter or whatever, and you know, then you wear it a few days, it'll initially deprogram the muscles and give them a little relief at first, but then you'll see that the problem will get worse or over time, or they stop wearing it because it's not comfortable.
Is there anybody who's not a candidate for this kind of appliance, like if they have a partial or significant
no.
amount of missing
No,
teeth?
in fact, sometimes you'll also see it in denture patients. That, you know, they become overclosed and you know, because that overclosure and everything happens gradually, sometimes they don't even know they've got, I mean, they'll have symptoms that they've lived with for years, but, you know, so a denture patient that comes in that's overclosed, I always ask or we check about the joints. Because the other thing you wanna think about is all of a sudden you're opening that bite and they've got a lot of wear, sometimes again, you can trigger a problem. So somebody that's overclosed, I talk to them about considering doing the testing, and we make a little orthotic that'll fit over the lower denture, and again, we have them wear that for 3 to 6 months to make sure the joints are gonna accommodate that new position. And then if they do, then that tells us, again, where we wanna be occlusally with the new denture. Also, I think, and Dr. Biggs, I think, is working on a couple of cases that are or full mouth reconstructive cases that, again, we do the orthotic that, and
They'll be in February.
yeah, Doug, for example, I mean, we've talked for him for 15 years, 10 years about needing to do something, and I'm glad he is, but again, we wanna make sure that, again, by opening that bite, that he's gonna function in that position, okay? A lot of times you'll find that if somebody's got a lot of wear of their teeth, you can look at that radiograph, and sometimes you'll see the wear of the condyle also. So that's all I really had on TMJ. You know, I think, you know, at some point, I don't know we'll have time today, but at some point if you want Becky or Mariah to kind of show you the testing or show you a little bit more about that, we can. Usually we allow 2 hours for that appointment to do the testing. By the time we get impressions, we pull some for an hour and then we get our test done. It's about a 2-hour appointment. So the next part is sleep apnea. Sleep apnea is when you're not moving any air through. Would you pass out these stirring straws? Stirs.
Sure.
Coffee stirs. Where you're
Becky,
not
can you
moving
get him
any-
so I don't go through the camera?
any air at night, so some people come in and they'll want a snoring appliance, and there are appliances that are, say they're for snoring, usually they're not an FDA approved appliance. Sometimes they can reduce snoring, sometimes not. Snoring isn't
Down a straw.
the concern, it's when you stop moving air and have sleep apnea. So there's also, you may not have sleep apnea, but some people will have something called hypopnea. And so when we do our testing, basically we're testing for apnea and hypopnea, or when a patient's been in a sleep lab, it'll give you a report, an AHI number, and an apnea hypopnea index is telling how many episodes an hour a patient's going without air, limited airway. So if you take your drinking straw, put it in your mouth, pinch your nose, and just kind of breathe. Start, I don't have a second. Just kind of see how long you can breathe comfortably like that. So that's hypopnea. That's typically how much air a person's moving that has hypopnea. And there will be people that will have that for a minute and a half, 2 minutes or so. That's how much air they're getting. There are also people that move no air for that period of time. So of course that puts the patient at risk. The blood pressure goes up, their heart rate goes up, their blood sugar levels go up. They're at risk to have a stroke, a heart attack. It's a lot of stresses on the body. Also the daytime drowsiness. They say a lot of the people that run off the road, have the accidents on the highway. They're people that have apnea. They've fallen asleep at the wheel. Truck drivers, again, they're starting to check truck drivers for, make sure they don't have sleep apnea because of accidents and relating that to those that have sleep apnea. Dentists get involved in this because, for a couple of reasons. One, we see patients usually a couple times a year. Sometimes we see patients more often than they see their physician, and there are some clues that we can have regarding sleep apnea on exam. Again, some of the same things that you see with TMJ problems, with the signs of bruxism, because people that have apnea, when they lose their airway, they'll go through, their jaw will go through these motions trying to establish an airway, and a lot of times you'll see the grinding or wear patterns. Maybe kind of getting out of order a little bit, but so when you see somebody that has the wear patterns, we talk about, are you aware of clenching or grinding? Do you think you do it at night? And then I always ask about, do you think you have you ever been told you have sleep apnea, or does your partner ever say that you stop breathing, or do you wake yourself at night? Sometimes people, when they have an apnea event, they're without the air, and then it gasp, and they'll wake themselves up or wake somebody else up because of that big inhale. So you see that also on exam. Their uvula, if it's a large, people have real big uvula, or it's red, or if the throat's red in absence of any other type of sinus problem or whatever. It's because of the vibrations that occur through the apnea, and also people that are snorers will have that occur. Also, when the patient's sitting back and hygienist is working, you're doing your exam, you're looking at, there's no airway between the way their palate sets and their tongue sets. There's no way to move the air. Again, those are patients I talk to about it. What else? So anyway, those are say some things you'll notice as being in the dental field that can start the conversation. A lot of the patients that we treat are patients that are referred to us from sleep clinic. Dentists get involved in this because statistically about 40% of those that are given a CPAP are intolerant for one reason or the other. A lot of people they're claustrophobic, or they don't like the bulk up, so then they're just not treated. They're diagnosed that they need it, and then they're not being treated. CPAP is 100% effective because they can titrate, they can set that oxygen to a level to correct the apnea. But again, whether the patient will wear it or not is the thing. Some people that have more severe apnea and have to have their pressure set real high sometimes could consider an appliance plus the CPAP. The CPAP pressures could be set down low enough that it's not like they're in this wind tunnel, at night. So, that sometimes can be an indication, something we've worked with the sleep lab on. So there are FDA-approved appliances for sleep apnea. The appliance we place is called the Respire appliance. There was another appliance we did at one point. It worked well, but it was more cumbersome. This looks cumbersome, but we've had some little old ladies and people that I've, oh my God, it's gonna be such a mouthful. Yeah, and look,
It
young
is a
lady.
mouthful. It is a little old lady.
But,
I'm little.
anyway, carpet fits on the top or bottom. There are these wings that prevent, when you lie back, prevent the jaw from settling back.
Can someone with TMJ wear that?
Yeah, so, yeah, well,
Okay.
so when we're, so when we're doing an exam, so if we're gonna be speaking to a patient about doing an appliance, and again, a lot of times those are patients who've been referred to us, one of the first questions we ask is, do they have TMJ problems? We palpate the joints, check that. Because again, if we're changing that jaw position, we can trigger a TMJ problem. If we think they may have that problem, then we probably would recommend doing joint testing to know what kind of problem they have, and just make sure that they were. But I'm making too much noise for your video. Sorry. So we would screen, do the TMJ. Now I'm gonna be.
Right.
Let's see, what else? So we check that patients, so with the sleep appliance, a patient that has a denture cannot have the appliance. They can have partials and have it, but not dentures. They have to be current on their dental care. There can't be presence of periodontal disease or gum disease. If they need just a small or routine filling or two, that's not a big deal. But again, people that need a lot of restorative work, they've got fractured teeth and all that, they need to have that taken care of before we do an appliance. Not just the fit of the appliance, but again, we don't want the appliance to trigger other problems. That's all about that. So when, and then with that appointment too, then we, one of the biggest parts of it then is making sure we jump through all the hoops for insurance, because medical insurances have different requirements on whether or not they'll pay for the appliance, or under what stipulations they'll pay for the appliance. Medicare, for example, if they have a CPAP, they have to have had CPAP longer than 5 years.
They cannot have paid for an appliance or a CPAP in less than 5 years, or they won't cover it.
Yeah, and so again, different insurances have different parameters. So at that first appointment too, front desk will be able to help that patient through knowing what their insurance requires. Usually when the patient calls for the appointment, we get their insurance information, so we already know what that insurance company's gonna want before. If they have a CPAP and they're intolerant, they have to sign an intolerance form. We have to have a script from a physician. As a dentist, I can't diagnose sleep apnea. I can screen for it. I can't treat it without a script from a physician. There is, I don't do this, but we can have a patient taken and bled at home if again it's showing numbers that look like they may have sleep apnea. We can electronically send their recordings from the Imbleta to a service, and they review it, and then sleep physicians at that service can write the script for it. I just haven't tended to go that route. I feel more comfortable working with the local sleep lab and that. If we have patients here that we think may have sleep apnea, we offer for them to take the Imbleta home to screen for it. And again, if it looks like their numbers are with a certain threshold, then we'll send that to sleep lab, or their physician can refer them. The important thing is that they get treatment. Let's see, so when we do the testing, you know, we have, we want a panel roll, we want to be able to check, again, screening the joints, screening for any other dental disease that patient may not be aware of that they have. We take alginate with this one, because there's a part that fits on the top or bottom, both are poured in the blue or green stone. They have to be very accurate impressions. And then we use something called a pharyngometer. You've all probably seen that. It's kind of a tube-like device. We have the patient just inhale and exhale through it, and the pharyngometer measures at different levels what your airway volume is, and then we have the patient pinch the nose, blow out all their, or take a big inhale, blow out all their air to simulate an apnea event, and then again measure what their minimum volume is when they have all their air exhaled. Then we have little jigs that are different millimeter openings and different either end-on-end bite, or could be 2 to 3 millimeter, I think even 4 millimeter advancement of the jaw. We have them do the same exhale through that with their nose pinched. So again, if they were having an apnea event, but their jaw was in such and such position, what's the volume of air that they're moving? So we're finding the position that has them, their jaw in the least amount of open or least amount of advancement, that gives us the highest volume of air. Something that you also will find, so sets us apart from other offices that do this. Sometimes they'll get another office might get a script from a physician for an appliance, and they just take a random bite relation, maybe have the jaw person bite more end on end, make the appliance to an arbitrary position, go from there. If there isn't any testing to know if that's a better position or not. I think Becky, since she's worked with me more, can tell you sometimes you can take one of those spacers and do something where you think, well, their jaws are open more, that should create more of an airway, but sometimes they can make it worse. So you know, we just want to know what we're doing is going to help or correct the problem. With the oral appliance, I never tell a patient it's going to 100% correct their problem. By definition, usually they consider a patient that needs treatment as somebody that has 5 or more episodes an hour. Some insurances, that number's higher.
Well, like Blue Cross Blue Shield of Kansas, they will not cover it unless they have 15 or
yeah.
more, and so that means that they are just on the low end of moderate.
Yeah.
So that,
So then they classify sleep apnea as mild, moderate, and severe. These appliances are okayed for mild to moderate apnea. Again, severe would only be with physician's approval, and usually with a combination of a CPAP. So the patient gets the appliance. It's a short appointment to deliver it, and this lab does an amazing job. You know, they always fit very well the first time you try them in. We have the patient wear 2 weeks, tell them it's 2 weeks to get used to the appliance. And then when they come in for their first appointment, again, it's a short appointment. We're really wanting to check to see how the joints are doing. One thing the patient will get when they get the appliance is a little wafer that they can heat in hot water and bite into, because again, after they've worn that appliance all night, you first take the appliance out and you bite. That jaw's going to want to guide to where the bite was on the appliance, and so they're going to feel like, my back teeth don't come together and smooth my teeth. Well, I haven't moved the teeth. Again, that's where the joint muscles have the position they've learned overnight, so that's where we want to guide to. So people that feel like their muscles are a little tight in the morning, I mean, not pain, but just kind of a little tight, they can kind of bite and chew on that for a minute or so and it loosen things up. We don't tend to have a lot of problems with that patients tell us about. It's the same thing with the orthotic. When patients have worn that orthotic 24 hours a day, they take it out to eat, they'll feel like, you know, all the teeth don't come together. Again, it's not moving the teeth, but it's that jaws, that's the position it's gonna wanna guide it. When we start decreasing wear time on an orthotic, the patient can more easily transition between the position with the orthotic and without it, so it becomes less of an issue then. So they've had 2 weeks, we have our short check, and then we ask them to come back in 2 months. They recommend at 2 months, then you do another sleep study, just to give them 2 months to get used to the appliance and to see what kind of improvement they're gonna get. So again, with the wearing the appliance, they can kind of hook themselves up to the Embledda. That's the unit we have here. It's easy to learn how to give directions for a patient to use that. So they test overnight, they drop that off, we download the information, see what kind of improvement we have, and then we share that information back with the sleep lab and the patient. If we find that there isn't adequate improvement, these appliances can be adjusted for more of an anterior positioning, or if it really looks like it's, you know, hadn't really improved, and you know, I'm concerned about that, I might retest them to see if we need to have the lab change that, you know, some aspect of the eye. And then from there, we should, once a year, do an Embledda with the appliance again to make sure the appliance is doing what it should. Okay?
If someone has a CPAP, can they wear both a night guard and an orthotic? Like either? Like if someone has wear on their teeth, but they don't have any symptoms, no
Yeah,
clicking,
that should-
popping, you
should-
can recommend a
yeah.
night guard, and then same thing for an orthotic?
Yeah.
Okay. If they have a CPAP and like wear it fine, but then they have grinding, are we
Well,
allowed
again, I guess
to
the
recommend
the
switching?
The question would be how long did the grinding occur before they started CPAP, because if they were a nighttime grinder, if they have the
Mhm.
CPAP, they're probably not grinding anymore.
If they say they've had it for 10 years, but they're a new patient, what do you recommend?
Yeah, I would just have them be aware of any grinding. If they're regularly using their CPAP, again, you know, I don't know, I mean, I guess they could do, but I would just wonder if the wear occurred prior to the CPAP, and, I mean, that would be a hard thing to know, but, you know, so you might wanna watch for any signs that maybe they're having any increased abfraction or occlusal wear, and then decide if maybe they need the night guard too. Okay. Any other questions?
So if someone, we're talking to them about sleep apnea and they've never talked to their physician or anything, what button are we pushing?
Okay, so if they, if you ask if they have daytime drowsiness, yeah, I know I snore, and, you know, got some, kinda headed that way, there's something called an Epworth sleepiness sleep scale, and so there's a form, one-page form they fill out, and then you score it, it tells you how to score it, depending on how they mark the boxes, and if they're a certain range, then that would tell you that, like, she has.
It's example 1 in everybody's packet.
So then that would be, then I really recommend that you have a sleep test. So some people won't go into to do a sleep test because they don't wanna do the overnight sleep study. Most times, what they'll require is a patient go in, spend the night in the sleep lab, and they have more leads, and it's more testing than what we do with the home monitor, but, so if a patient, when they're in the sleep lab and they've got a tech there, in another room kind of watching them sleep and monitoring all this information, the patient goes into apnea, they'll come in, put the CPAP on them, and they titrate or set the oxygen, let the patient go back to sleep, make sure that set right, and kinda, they do that, that's how they determine the setting for the CPAP. Some patients just don't wanna go through that, and so the Embledda is a home study that's acceptable for diagnosis. The sleep lab now, I think, is doing, they're using an Embledda or similar
Some like
unit
the
now.
star
something.
unit.
And I think it's dependent upon, maybe a person's insurance. It's certainly a lot less expensive for an insurance to pay on a home study than it is, the overnight stay, but. So anyway, so then I would offer the Embleta to them,
So we just have them push the Embleta button.
So the preface is if you are talking to a patient and you're filling the patient out and the patient is like, well, maybe I'll think about it, that there is the recommended ZZ button, and that is the recommended for the Embleta. So no fee goes into it, but it shows that you've actually talked to the patient.
so I don't know about these buttons. What you're talking
But if you are talking to the patient and they're like, yeah, my wife is like Chad, his wife was just like complaining, he is snoring so loud I can't sleep, and they really want to move forward, then there is actually an Embleta button also you can push. It is $80 for the patient to do.
The thing is
Insurance
that
will not cover
it's
it.
like $20,000, and so.
So there is also, in here, there is an example for the Embleta